everyone. I'm Yunfang, an associate professor at Central Michigan University in the United States. Today, I will talk about the diagnosis and treatment of hidden hearing loss. I will give an introduction of the hidden hearing loss first, then focus on the diagnosis and treatment. So what is hidden hearing loss? Let's take a look at this figure. This is the organ faculty, a sensory organ of hearing in the cochlea. It has two types of hair cells, the inner hair cell and outer hair cell. Well, the inner hair cells are the ones that are responsible for transducing mechanical energy in the middle ear to the electrochemical energy in the auditory nerve. The inner hair cell here connects to the afferent nerve fiber through the synapse. Well, the hearing disorder with lesions, specifically the synapse between the inner hair cell and afferent nerve fiber, is called hidden hearing loss. Obviously, it is peripheral hearing disorder. It's also called cochlear or auditory synaptopathy or cochlear neuropathy. Why do we call it hidden hearing loss? Let's take a look at this figure. We define hearing loss based on the thresholds in dBHL at different frequencies, usually at 250 to 8,000 hertz. For adults, when the thresholds are above 25 dBHL, there is a hearing loss. Well, for a child, above 15 dBHL, there is a hearing loss. Individuals with the hidden hearing loss have different perceptual hearing difficulties, such as difficulty hearing in noise, tinnitus, hyperacusis, or they have difficulty communicating with others in different listening environments. However, their hearing thresholds are within normal limits in the audiogram, so it is called hidden hearing loss. To understand why it is hidden from the audiogram, we needed to look at the subgroups of the auditory nerve. This is the inner hair cell. It is connected or innervated by three subgroups of the auditory nerve: the low, mid, and high spontaneous rate nerve fibers. The high spontaneous rate nerve fibers have thickest axons located on the pillar side of the inner hair cells with more mitochondria and have low neural thresholds, which means it will respond to low level sounds. Let's take a look at the figure here. It has stimulus level from low to high and the neural response from low to high for high, mid, and low spontaneous rate nerve fibers. The dotted line here indicated the lowest level that will start to stimulate the nerve. So from here, you can see only the high spontaneous rate nerve fibers will respond to the low level sounds at about 20 dB SPL. So the high spontaneous rate nerve fibers are responsible for thresholds in the audiogram. While the low spontaneous rate nerve fibers here have thinnest axons located on the pillar side of the inner hair cells with fewer mitochondria, which means it is more vulnerable to external factors like noise, other toxic medications, and aging compared to other subgroups. So hidden hearing loss, actually, it is specifically due to the damage to the low spontaneous rate nerve fibers. Also look at here. It will only stimulated by moderate to loud level sounds. So if there's any lesion happened to this specific nerve fiber, it was not detected by the audiogram. Well, due to the damage of the low spontaneous rate nerve fibers, the whole intensity dynamic range is reduced, which will lead to hypoacusis. Also, neural damage will cause sound coding deficits in temporal and frequency processing, which will lead to reduced speech intelligibility, difficulty hearing in noise. So people with hidden hearing loss will have perceptual hearing difficulties, but will not be detected by the audiogram. It is found that the common causes of hidden hearing loss are noise, aging, and other toxic drugs. And they will affect the synapse first, causing overproduction of neurotransmitters, leading to hidden hearing loss. Also, the combination of different factors will make it worse. And the viral infection can cause hidden hearing loss as well. Well, it is hidden from the two-tone audiometry. How can we detect this disorder? Researchers use a special immunostaining or serial section electron microscopy to dye different cells. Take a look here. You can clearly see different neurons here and count how many losses to validate the diagnosis, but it's not practical for human study. Also, the high field diffusion MRI with the high resolution images may provide estimation of nerve losses. However, it cannot help early detection because neurons may survive for a long time after synapse damage. So what can we do? So far, lots of research have been focusing on electrophysiology measures for hidden hearing loss diagnosis. It is non-invasive. Take a look here. You just put electrodes on the forehead, earlobe here, far field recording, but it can examine the neurosynchronous response. And this is the results from click ABR. The wave 1 from here is the response from the auditory nerve. Well, due to damage, specifically to the low spontaneous rate nerve fibers, the wave 1 amplitude will only reduce for mid to high level stimuli, not for the low level sounds. And it is confirmed a reliable diagnostic measure for animals, but may not be reliable for human hidden hearing loss diagnosis due to more inter and intra-subject variability among different individuals. Well, the weight 1:5 ratio measure in the same click ABR can help reduce within subject variability. But this measure might be affected by central processing and aging because weight 5 is primarily generated by the lateral lemniscus here in the brainstem. Same drawback will be for the weight 5 measurement. So researchers try to use ECOG measurement. It will measure the summating potential action potential ratio, which will also help limit the inter-subject variability. Also, the AP here is more prominent compared to in the ABR. While the AP here is the same as the ABR wave 1, which is the response from the auditory nerve. Well, for individuals with hidden hearing loss, the SP-AP ratio will increase due to the decreased AP, but it will further increase due to increase the SP because of the impaired acoustic reflex and a cochlear reflex due to damage specifically to the low spontaneous rate nerve fibers. But keep that in mind, the SP is one of the cochlear potential. So electrophysiology measures can help identify lesions, but also have some drawbacks. In addition, it takes a relatively long assessment time. So researchers explored the extended high-frequency audiometry, including testing frequencies above 8,000 hertz, and it showed elevated thresholds at those frequencies for people with hidden hearing loss. It is a simple tone detection test with a short test time. Also, the extended high frequency is more sensitive to the detection of the initial cochlear damage due to ototoxic medication and the noise exposure. So it could be an effective screening tool for early diagnosis of hidden hearing loss. Well, other behavior tests like speech in noise and reverberation can target perceptual difficulties and indicating poorer than normal performance for hidden hearing loss. One thing I want to point out is the UCL measure. It is easy, quick, can help hyperacusis assessment, while people with hidden hearing loss usually have reduced UCLs. Other than the evaluations, questionnaires should be an important part of assessment. As a clinician, we should always listen to the patients. This way we can know their hearing difficulties and possible etiologies, like have they exposed to loud noises. As we know, one impulsive loud sounds can cause permanent nerve damage and lead to different hearing difficulties. Of course, a conventional comprehensive hearing evaluation is necessary to provide a basic hearing status and help differentiate the hidden hearing loss from hearing loss. Well, here I want to point out is to include DPOAE as a part of the diagnostic protocol for hidden hearing loss. And it's if possible with extended high frequency. And this way it can indicate the auditory nerve function and provide outer hair cell function and provide variable information regarding underlying etiology of perceptual difficulties such as hearing difficulty in noise. So in summary, a comprehensive test battery, including questionnaire to electrophysiology measures, is necessary for diagnosis of hidden hearing loss to reduce within and between subjective variability and serve as a cross-check to increase diagnostic accuracy. Well, individuals with central issues like auditory presence disorders, cognitive deficits, etc., they can also have perceptual hearing difficulties, but hidden from the audiogram. But this way, electrophysiology evaluations such as ABR, mid-latency response, and late latency response may help differentiate the site of a lesion. As we know, hidden hearing loss is from peripheral. So the wave one amplitude will decrease, but not for more central waves. While central issues will have the opposite responses. Auditory neuropathy is also a peripheral hearing disorder, but the click ABR would be enough to differentiate hidden hearing loss from the auditory neuropathy. Take a look here. This is from the auditory neuropathy results. We cannot see any waves here except the cochlear microphonics. It will change polarity according to the stimuli changing from rarefaction to condensation. Well, the hidden hearing loss will have waves. Meniere's disease also has increased SBAP, but it has a unique characteristic symptoms which will help for the differential diagnosis. Well, studies have been trying to find treatments for hidden hearing loss, but so far, the effective direct treatments are only for animals. Well, for human, we're still focusing on the symptom reduction treatment and the prevention of damage. It was found that when delivering the neurotrophin or pharmacological inhibitor compound C and siRNA to the round window, either before or after noise exposure, can help preserve auditory function. Again, these are only for animals. So for human, what can we do? Hearing aids. Hearing aids can help reduce the perceptual hearing difficulties. But remember, patients with hidden hearing loss have normal hearing sensitivity, but have perceptual difficulties due to coding deficits in temporal, frequency, and intensity. So it is suggested to use binaural amplification, but with mild gain and with appropriate features like noise reduction, directional mic, speech enhancement, etc., to help improve hearing and noise. We can also use tinnitus program for the tinnitus therapy. You may also want to reduce MPO to avoid the uncomfortable loudness perception for some patients. Auditory training can also help improve different perceptual difficulties. As we all know, neuroplasticity is amazing. When practicing more in noise, the ability to recognize speech in noise will improve. Also, low-level sound therapy can help with tinnitus and hyperacusis. And the music training can help as well. Since most hidden hearing losses are acquired, like after noise exposure, having other toxic medications, so prevention is important and possible. It's found that the long-term low-level sound exposure can cause hidden hearing loss. So we need to advise people to wear your protection whenever exposed to loud sounds, and try not to listen to loud music via headphones for a long time. If individuals work in noisy environments, have ototoxic medications, or age 45 to 50 and older, there is a need to monitor hearing sensitivity. So in summary, cochlear synaptopathy is a disorder with damage occurring at synapses between the inner hair cells and afferent nerve fibers, specifically at the low spontaneous rate nerve endings, causing perceptual difficulties, but cannot be detected by current standard hearing diagnostic procedures. So it is recommended to use comprehensive test battery to cross-check and reduce the variability. While for the differential diagnosis, mostly it is central issues. And current treatment for human is still focusing on symptom reduction, hearing protection, and monitoring. This is my presentation, and here are my references.